Assalamu alaikum students. Today we'll be discussing the various aspects of cardiac failure. Uh, we have a busy schedule in this lecture. First, we'll define cardiac failure, look at its various causes, go into some details of the stages of the cardiac failure, together with what the body does in terms of compensation. Then we'll look at the types, the clinical manifestations, i.e. signs and symptoms. And at the end, we will conclude by looking at cardiogenic shock, which then will proceed tomorrow on the concluding lecture of various circulatory types of shock. So what is cardiac failure? Basically, it's a failure of the heart to pump enough blood to come to the needs of the body. It's usually accompanied by, almost always accompanied by congestion in the peripheral organs. If it's the right side, if it's the right-sided failure, it will lead to congestion of the peripheral body. If it's the left-sided failure, it will lead to congestion of the lungs. So we call it congestive heart failure, and it's pathophysiology, meaning the what goes wrong. Basically, that's pathophysiology. It basically circles around two aspects: the decrease in cardiac output and the compensation that the body puts up. Okay, so this is a nice table to show you an outline of the causes of cardiac failure. On the left, you'll see impaired cardiac function. So there's something wrong with the heart itself. And the other is excessive work demand, whereby you need to understand that the heart itself originally was not at fault. There was something funny going on in the rest of the body, which then put excessive work demand on the heart, and eventually heart went into failure. We look at the impaired function first. So myocardial disease, the myocardium itself has developed some problem. It has changed its shape, maybe has dilated abnormally. If there's an infection somewhere, the coronaries are insufficiently supplying blood to the myocardium, or there is blatant myocardial infarction, which basically means part of the myocardium is not functioning now. There can be problems with the valve. Maybe there is stenosis or regurgitation, or maybe there is a heart defects right from the birth. And if all of this is okay, the covering of the heart, pericardium, that may be problematic and can lead to cardiac failure. The second column here is excessive work demand. This is interesting because the heart originally, as I said, is okay, but there might be increased pressure work. So there's the same old hypertension comes in, systemic or pulmonary. So the afterload increases significantly, which means that the heart needs to now compensate for the increase in afterload scenario and has to pump extraordinarily, which then leads to hypertrophy of the ventricular muscle and eventually leads to cardiac failure. Increased work volume is we've discussed this, AV shunt. So arterial blood shunts into the venous side, bypassing the tissues. The tissues become hypoxic. That gives a signal to the heart that the perfusion is not happening, the oxygen demand is not being met, substrate demand is not being met, and hence the heart translates that into even more cardiac output, and so eventually fails. Excessive intravenous fluids, again, the preload would increase, and that would eventually lead to problems. Increased perfusion work is also interesting. So there are diseases, thyrotoxicosis, that is hyperthyroidism. You will study this in endocrinology, or anemia, where the demand for circulation increases so much that the heart eventually gives out. These are some of the causes, some of the outlines of cardiac failure. This by no means is exhaustive. You will obviously be dealing with this issue, a very common issue, by the way, much more in detail and from the treatment and management point of view in clinical medicine. Okay. Now, the stages of cardiac failure. So cardiac failure doesn't just happen, not in all cases. In a few cases, indeed, it just happens suddenly and it leads to death, and that's the end of the story. But generally speaking, it does follow a course. So there is an acute stage, and remember we're talking about moderate cardiac failure. So in moderate cardiac failure, there's an acute phase in which you have the two features, the decreased cardiac output as I mentioned, and the resultant congestion, which here is mentioned as venous pooling, whether it's systemic venous pooling or lungs, depends on which side of the heart has failed. Um, and just a footnote here, if the initial cardiac failure is severe, i.e. not moderate, if it's massive, it's too much. For example, some MIs are so big, the infarction is so big that the rest of the heart just, doesn't matter anymore. In this case, unfortunately, death happens suddenly during the acute phase. So as soon as the symptoms come in of cardiac failure, the person dies within hours. So this being an exception, we'll go back to the moderate cardiac failure. So acute phase of moderate cardiac failure is basically all symptoms and all the signs which come around because of decreased cardiac output and venous pooling. Then you have chronic stage of this moderate cardiac failure, in which, as I mentioned, the compensatory mechanisms, they kick in, and they sort of save the day, proverbially speaking. We call it recovered, or recovery has happened. And this heart now is compensated. Of course, it's not as good as the original heart, quote unquote. It is recovered or compensated, but it does the job, and with certain dietary restrictions and certain exercise protocol, the person lives a normal life. So that's moderate cardiac failure. However, there's another type, which obviously either the massive cardiac failure led to death, or if the person survives, then he or she enters a more chronic stage, in which no type of recovery is possible, and we call it uncompensated cardiac failure. And eventually, this person struggles his or her way to demise. Okay, so this is an overall slide discussing the various stages of cardiac failure. The moderate, and in case it's severe, the acute is certain death, and more chronic of severe cardiac failure is basically an uncompensated cardiac failure. I would like you to remember from this slide the two key words which are colored here: compensated cardiac failure and uncompensated cardiac failure. Please remember that compensated cardiac failure is of moderate failures, while uncompensated is either the moderate cardiac failure has not been managed properly and it has entered into uncompensated, or that the initial injury, insult, was so severe that there is no recovery phase or a phase where construction can happen. It directly goes into an uncompensated phase. Okay, so we are now talking about the compensated cardiac failure. Okay, we looked at the acute phase. We look at the chronic phase. The acute phase is 30 seconds to a minute, so it's very tight window really, and you can see how seconds count post cardiac failure. And this is where the patient, as you will see, is struggling to manage this acute phase by loading up compensatory mechanisms, so that the cardiac output is improved and the venous pooling is addressed. Okay, it's all about that. Remember, it's all about increasing the cardiac output, and it's all about decreasing the congestion, avoiding the edema, and all that sort of business. And one more thing before we go into this in detail is the heart and kidney. They basically, you need to imagine that the heart and kidney and circulation, these are the three main actors in cardiac failure, all right? If you decrease the cardiac output significantly, you basically decrease the renal perfusion. And when you decrease the renal perfusion, the kidney translates that into the kidney needs to retain fluid. Whenever you decrease tissue perfusion of the kidney will retain fluid. Okay, so that's one thing. When you decrease cardiac output as a result of cardiac failure, the kidney's perfusion will go down, and it will start retaining water in an already stasis-ridden circulation. So you already have congestion because of cardiac failure, and on top of this, kidney has decided to retain more fluid. This is a very bad situation. And this you will see throughout the compensated and indeed in the uncompensated cardiac failure. This is what basically breaks the camel's back, proverbially speaking. So remember, heart, kidney, and circulation. These are the three actors which we'll be discussing throughout cardiac failure. So we start from this graph. It's a very nice graph of Guyton. It's that typical cardiac function curve that we have been discussing in the previous lectures. So cardiac output is plotted on the y-axis and right atrial pressure on the I beg your pardon, cardiac output on the y-axis and right atrial pressure on the x-axis. And the red curve here is the normal curve. Okay, this is the normal. If you remember, this is the normal cardiac function curve. Now the acutely damaged heart is in blue. So this heart, it was functioning fine, but suddenly there was an MI, myocardial infarction, or something went wrong from the cause list that we discussed. So this dropped and became the blue curve. So you can now see that there are two issues with this blue curve, and you should be able to read this analytically now because we have discussed in detail the cardiac function curve. So if you drop this curve to the right and closer to the x-axis, which basically means that cardiac output has obviously decreased. The point A is normal cardiac output, 5 liters per minute. It has now plummeted to point B, okay, which is nearly half. So clearly, this is a significant heart failure. And this plummeted down, and this basically resulted in an increased right atrial pressure. And you should be able to now work out why did the arterial pressure increase? Because the heart is not pumping enough, and the blood is being collecting in the heart. It's being dumped in the heart. The preload is coming through. The venous return is coming through, but cardiac output has dropped. So within the heart, you will have increased preload, which basically increases the right atrial pressure. And this is a very bad situation. Okay, so now the heart went from point A to point B. Okay, but then something happened. The acute phase compensation happened. So then what happened is how do you describe this color? It's a dark greenish color, all right. Okay, so it basically the cardiac function curve then went from this blue line to this dark greenish line. Okay, and now we have a new point, the point C. This is where the damaged heart was improved or helped by the sympathetic stimulation. Okay, so things improved, cardiac output improved, and right atrial pressure not so much, because definitely the heart is in the failure stage. And this is the problem with heart failure, that you have compensation, you sort of improve the function of the heart by addressing the cardiac output, but it's not enough to clear out the heart from its backlog, from the preload, the venous return which is coming in, and hence it's always struggling with that preload, which is depicted along the right atrial pressure curve. Then later on, you do the chronic phase, and you do some more stuff which we'll discuss, and you have a partially recovered heart. Point D basically means that the heart is now recovered, compensated. Okay, it's the compensated heart, and this light green curve basically is of the compensated heart. So it began from this red line, normal person, heart failure took place, acute phase, then acute recovery happened, and then you have a chronic recovery that happened along this light green line, and point D then became your reference point from point A. So this is the story of the heart failure, which went from A to D. Okay, now we'll look at the acute phase. As I mentioned, it basically manifests as a decrease in cardiac output and venous pooling. Okay, now compensation now will happen through the sympathetic nervous system reflexes, the baroreceptor, the CNS ischemic response, and chemoreceptor reflex response, all that you have discussed under control of arterial blood pressure. They come into play because as soon as you have decreased cardiac output, you will have decreased blood pressure. I hope you remember the formula for blood pressure is cardiac output into total peripheral resistance. So if you decrease cardiac output, you decrease blood pressure. It's the decreasing blood pressure that basically signals to the sympathetic nervous system through baroreceptors and all those reflexes to increase contractility and heart rate. Okay, and then also increases venous return by squeezing the veins, the capacitance vessels basically. They are also squeezed to improve venous return further. Now, this is the mainstay. This is when we say compensation. This is the acute compensatory mechanism. Somebody asks you in a viva, how does cardiac failure compensation work in the acute phase? You pop out this question, this answer rather. So the sympathetic nervous system gets active. It improves contractility, improves rate, and increases venous return. And this happens within a minute. Okay, so a point to note. Then what happens? Then basically the chronic phase happens, which spans from minutes to days. What happens in this? Now, this is a very important point here. Fluid retention by the kidneys. Now, I mentioned just now that you need to remember those three things, the heart, kidney, and circulation, right? And I described fluid retention as a bad thing. Keep that in mind, okay? But now we will add a little more finesse to that argument. A little fluid retention, or rather the initial fluid retention by the kidneys, when they sensed that something bad has happened, they calculated from the decreased perfusion due to the decreased cardiac output that something has gone wrong, and they started retaining fluid. Initially, this is not a bad thing, really. It's the problem is, I'll first tell you why is it not a bad thing, because it tends to improve the MSFP, the mean circulatory filling pressure, which basically improves the venous return, and here the Frank-Starling law tries to jumpstart the cardiac output. However, too much fluid retention is basically the feature of a failing heart. Okay, and that basically is the congestive part of congestive cardiac failure. Okay, so too much fluid retention, if the heart does not address, look, it's a whole, remember the diagram that we discussed of the pump and the two tubes, okay, right, in the initial discussions. The heart is not doing its job. It's not providing the movement of the fluid. The fluid is now accumulating in the periphery, either in the lungs or in the periphery, it doesn't matter. The problem is the fluid is not circulating properly. You will have congestion. You will have the cardiac output will be struggling because it needs that venous return to come in, and then it pumps it further. So the basic issue is fluids displacement from not coming back to the heart and collecting elsewhere. However, during moderate cardiac failures, compensated phase, the initial fluid retention is a good thing. Too much fluid retention is a bad thing, and I would like you to note this down somewhere. Why is too much of fluid retention a bad thing? Number one, it increases the workload on the heart. Okay, obviously, and the heart is already not in a very spiffy situation. Then number two, it overstretches the heart, so it further increases the physical load on the heart. Number three and four are the two edemas. It eventually leads to edema in the lungs, which open the door to all sorts of problems, as you have discussed in respiratory physiology, and peripheral edema, which obviously is a problem because it will decrease venous return. Okay, so once again, a little degree of initial fluid retention is a good thing because it improves MSFP, venous return, and hence Frank-Starling law induced cardiac output. Too much fluid retention due to these four issues is not good, and we move forwards. The second point of chronic phase or chronic compensation is the heart recovery itself. So for example, the heart basically was faced an infarcted area. What to do now? All of this, if you notice, all of this, these are secondary things. This is beating about the bush in that sense. It saves lives, okay? No, not undermining these things. These points save lives. So if it's the sympathetic nervous system basically kicks in and saves life by temporarily increasing contractility and improving venous return through it, let me say, doesn't address the issue, does it? It's synthetic. It's basically manipulating the caliber, the diameter of the vessels. It's not addressing the main thing. Number two is fluid retention. Fluid retention is done by kidneys. Again, this is a manipulation with ECF volume to improve cardiac output through increasing venous return. So in fact, it's actually putting a bit of a load on the heart itself, right? It's depending on the heart, but who's going to address the heart? So in chronic phase, after many minutes or hours and right up to days, what starts to happen is the heart itself starts to recover. If this is to go to a full compensated scenario, it basically goes into recovery, which spans from weeks and months. And you know angiogenesis, we've discussed this in local blood flow control. New vessels, new collaterals of the coronaries, they start sprouting up, and you have better blood supply of the heart. And then the undamaged portion of myocardium goes into hypertrophy, which then improves the functioning of the remaining myocardium. This is how the heart itself improves and recovers and adds to the overall compensation. So now we basically are continuing with our scenario of cardiac failure, but this heart has had a severe beating. So it's severe cardiac failure. It will eventually go and become a decompensated cardiac failure, which basically will lead to death. Okay. Now the features of this type of cardiac failure is that the retention, the fluid retention is more and more. So remember the three things. Keep that in mind. The three things. So in this, a failing heart, together with kidneys progressive. The word progressive means it increases in degree, but with the passage of time, and retains more and more and more fluid. And this basically caused the MSFP to increase progressively. And then there's a progressive increase in right atrial pressure. And eventually, the heart becomes so stretched and or edematous that it just cannot even maintain a low cardiac output or a minimum decent cardiac output. And then it fails completely, which leads to death. Okay. Now, if you look at this, you will hardly recognize this as a cardiac function curve. It's so bad. Okay. So this constant line here it was the gold standard of the cardiac output, the 5 liter per minute. But look at this heart. So it basically its point A is way down at half of the cardiac failure. Okay. And then look at its projection. It's very bad. It's like an arc. So it does try to address the issue, the failing heart, and the rest of the sympathetic nervous system and all that. It tries to improve the situation, but look at the position of B as compared to A. It's not much. It does go to C and D, and then these two are the highest points, which then lead to the final decline, the E and then the F. Okay. And you can appreciate here that basically what is the normal MSFP? It's 7 mmHg. Okay, and at point F, it's 16. Okay, so this is a problem. The right atrial pressure, so much right atrial pressure is a problem, and then this is the cardiac function curve of a decompensated heart. So what do we do? Obviously, we cannot let this happen, sit and let the guy die out of the eventual decompensation. So basically, the treatment is quite literally the mirror effect of what the body does itself. What does the body do first? The first thing, the first port of call, sympathetic stimulation, right? So in treatment, you have cardiotonic drugs, which basically help the heart in its pumping ability. Digitalis is that number one drug that we give to improve cardiac output. And what does it belongs to a group of drugs called cardiotonic glycosides. And what do? How do they help? They basically improve the availability of calcium inside myocardial fibers so that they are available more in this time of need. Okay. And normally what happens is, very quickly, you must have studied this in the physiology of myocardium in heart physiology. Just to quickly revise, the calcium, when it comes out into the cytoplasm, so that it becomes available for actin myosin contraction in the cardiac muscle. It then, when it detaches, it then is exported out of the cell because it's not needed right now, right? When it's removed from the cytoplasm, it's absent. What digitalis does basically is it inhibits the sodium potassium ATPase. Now, what has sodium potassium ATPase have to do anything with calcium? It does, because the calcium is removed basically by exchanging it with sodium. And it's this sodium calcium exchange that gets disrupted when you inhibit the sodium potassium ATPase. The calcium stays inside and it's basically available for a greater amount of time to improve the contraction of the heart. So that's that. And we also can give sympathomimetic drugs to improve the heart to some extent. Of course, the heart is fragile at the moment, and these things need to be tapered accordingly. What was number two? The number two thing that was menacing in the mild cardiac failure was the fluid congestion, right? The collection of fluid in the tissues or in the lungs. And to address that, and that is basically what has created an absolute frenzy here. The fluid. We give a class of drugs called diuretics, which basically increase kidney excretion of fluid. They tell the kidney, they actually take control of the kidney and start to excrete more fluid, bypassing the kidney's habit of decreasing fluid output when the perfusion pressure decreases. That's like an inbuilt thing that makes sense to the kidney. But now you're giving a drug which bypasses that habit and basically increases fluid excretion by the kidney. Okay, so that's that. Okay, so there's a special mention of the peripheral edema in persisting cardiac failure, which basically is the chronic phase of any type of cardiac failure. The edema is a problem, and hence a slide just to discuss that, caused by the long-term retention of fluid by kidneys. What are the contributing factors of this formation of edema? Is basically a decreased GFR, glomerular filtration rate. We'll be discussing this in detail in second year, renal physiology. But I'm sure you've heard about this. The nephron has a glomerulus, which basically is the place where the fluid is filtered and then new filtrate is formed. Filtrate then goes into the tubule, and then all sorts of mechanisms happen on this fluid, and eventually it becomes urine. All this process basically decreases when there is cardiac failure, and it's because of this that you don't form enough GFR. The fluid is retained in the body, and that adds to the edema. Okay. Number two is the activation of renin-angiotensin system. We have discussed this in blood pressure control. You know that. And eventually, we know that it increases reabsorption of water and salt through the aldosterone mechanism. Thirdly, the aldosterone secretion, as I just mentioned. Four is basically activation of sympathetic nervous system, which is the first response of the compensatory mechanisms, as discussed in the previous slide. Now, this activation of sympathetic nervous system itself leads to further problems that add to your edema, and these issues include a couple of points. One is it basically vasoconstricts the afferent arteriole of the glomerulus. Okay, and again, when you read it in detail next year, this basically is a very significant factor. When you vasoconstrict the afferent, the feeding vessel of the glomerulus, you are basically decreasing the supply of blood into the glomerulus, which of course will lead to decreased GFR and add to the dumping of blood in the body, i.e., you are decreasing the access of blood into the kidney itself. So in this way, you are dumping the blood, you're retaining the blood in the circulation and adding to the woes of this patient. Number two is a sympathetic nervous system also activates increased salt and water reabsorption by tubular epithelial cells. There are alpha adrenergic receptors on those cells, those tubular epithelial cells of the nephron. When the sympathetic stimulation occurs, it enhances their salt and water reabsorption, again adding to the ECF volume, again adding to the fluid retention, the edema formation. Okay. Three is again, this sympathetic nervous system also activates renin, and the entire cascade of events that renin then triggers, eventually leading to increased salt and water reabsorption, again making problems for edema formation. And finally, it actually also activates ADH, which is antidiuretic hormone from the hypothalamus. And this hormone, basically, as the name indicates, it is designed to retain water in cases where there's dehydration. But in this situation, sympathetic nervous system directly activates it. The kidney then starts to retain extra water. And as you can imagine, this is not the desired situation in an already developing and menacing edema in the setting of heart failure. So this is this. Then we move on to the types of cardiac failure, as we mentioned in our learning objectives, based on pathophysiology and disease outcomes. So under these two headings, these are pathophysiology headings, and the disease outcome will be discussed at the end. Okay. Now, high and low output failure. What is high metabolic or high output failure is basically when the heart, I mentioned this in the causes, basically there's just too much demand in terms of cardiac output in an otherwise normal heart. So if you have severe anemia, thyrotoxicosis, or atrioventricular shunt, this is a high metabolic state, and the heart failure will be a high output failure, as opposed to a low output failure, which basically means that the heart is in itself has been damaged, and maybe due to ischemic heart disease or a cardiomyopathy, it has dilated to the point that it cannot properly contract. So the problem is within the heart itself, and it's unable to provide the normal needs of the body. Again, this is the same information, but given in a different, let's say we are looking at it at the same information that we've been discussing up till now, but in a slightly more clinical point of view. Okay, so this is one way to classify the cardiac failure. Another way to classify cardiac failure is to describe it as a systolic and diastolic function. So you have a situation where there's a systolic failure, which basically means that the contraction profile of the heart has been damaged. So the heart is not contracting enough blood, as opposed to a diastolic failure, which basically means that it's not being filled properly. Both are unique, both are different in their detail. So very briefly, a systolic failure basically will ensue when the heart itself has been damaged by, again, an ischemic heart disease or cardiomyopathy. There's a valvular defect, stenosis or regurgitation, or there is hypertension, which basically means that the heart's afterload has increased so much that it's now having trouble contracting against it. So all of this, basically, all of these things that I've just mentioned under the systolic failure, they lead to decreased ejection fraction. Okay, you know what ejection fraction is. Decreased ejection fraction, which then leads to increased EDV and diastolic volume, i.e. pooling of blood within the heart, increased ventricular dilatation. The heart is now expanding because of that pooling of blood, and there is increased wall tension without proper systole. Okay, all of this is bad for its oxygen consumption. The oxygen consumption goes up. Any coronary event can then lead to a very lethal outcome in this scenario. Okay. Coming to diastolic failure, which basically will hover around anything which leads to decreased filling of the ventricles during diastole. You may have a decreased chamber size. By chamber, I mean ventricular chamber. You can have a ventricular hypertrophy scenario, in the sense that it has expanded the whole muscle of the ventricle has hypertrophied, remodeled in such a way that it doesn't just protrude out, it also protrudes inwards, decreasing the chamber where the blood would have accumulated. So chronic hypertrophy scenarios basically also decrease chamber size and can lead to diastolic failure. This happens in chronic heart failures or chronic cases where the heart is gradually giving out, gradually decreasing in function, basically aging, with aging. Okay, and you have the cardiac remodeling happening all the time. It slightly increases in size, but eventually, obviously, it will be a bad thing. And again, something related with aging. There was nothing wrong with the chap throughout his life, but aging itself is a problem in the sense that it decreases ventricular wall compliance, the ability to stretch, contract and relax, contract and relax. It needs a very healthy, agile myocardium, which due to age, the actin myosin filaments, they basically um, age out, or they become, they're not very efficient in doing their function with the passage of years. And in itself, then this is a problem. In this type of failure, you have congestive symptoms more. In here, systolic, you have the decreased EDV. So decreased cardiac output is the main feature of systolic failure. But in the diastolic failure, you have more of the fluid retention side of things, which is obvious, and all sorts of problems with, say, mitral stenosis or cardiac myopathy with hypertrophy or with IHT. All all can feature a diastolic failure component. Then we've already discussed compensated cardiac failure. In this, cardiac output may become normal eventually, but at the cost of raised arterial pressure, atrial pressure, I beg your pardon, and decreased exercise tolerance, which basically the cardiac reserve, which basically means the ability to increase cardiac output in a normal person. You can really increase the cardiac output many folds in a normal person, while in an athlete, it's many hundreds of folds you can increase the cardiac profile, the cardiac output. But in that context, in a patient with cardiac failure, the cardiac reserve, i.e. the ability to improve cardiac failure in various situations, decreases tremendously. So while compensated heart is, you can live with that, but you need to be careful about your exercise, okay? And remember, it's set at a higher right atrial pressure. So you'll always have a situation where fluid retention or edema can set in your patient, and he needs to be, or she needs to be educated about this. And then finally, decompensated heart failure, which has no compensation, fluid retention becomes vicious. We've already discussed this in rather detail. Okay, so we are moving now to the conclusion of this lecture. We'll just wrap up by looking at clinical manifestations of right and left cardiac failure. So remember, although most of the cardiac failure basically does not have geographical boundaries as such, but sometimes it so happens that a side of the heart, one side of the heart is much more affected, or to the exclusion of the other side of the heart. So maybe the right side is more affected, the right ventricle is more affected, while the left ventricle is fine, or in most cases, the left ventricle is more affected than the right ventricle. Why is the left ventricle most affected in most of the cases? Is because the left ventricle's work, cardiac work, is much more against a increased afterload. Remember, the aorta is much more, what should I say, working against the aorta is a bigger issue than working against the lungs. Basically, the lungs vasculature, the pulmonary vasculature has a high compliance, low resistance. So right ventricle is a happy place, so to say. The left ventricle has to withstand the pressures of the aorta, which is formidable and can be formidable if there is even a slight change in the valve or in the aortic pressures, as is in early onset hypertension. All sorts of issues or all sorts of pressure is exerted on the left ventricle. So you have more MIs on the left side than the right side. However, for descriptive purposes, we'll just list down everything that happens purely, say, in a right heart failure. You'll have congestion of peripheral vessels. You can imagine whatever was coming up the ladder to the heart has basically come under pressure. You will have all sorts of edema, ascites, collection of fluid inside the abdomen. The GI tract, gastrointestinal tract will be congested. You will have all sorts of issues. These are the symptoms: weight loss, distress, general distress of the gastrointestinal tract. You have liver congestion, signs of impaired liver function. They are there. So this is basically if the right heart goes out. Coming to the left heart, basically you have the two main headings are decreased output, and decreased output basically means that you will have issues with tissue perfusion of the entire body. So it's a big issue here. And activity intolerance means the lack of increasing your exercise profile. So while you would climb upstairs or walk briskly, but now in cardiac failure, if it's especially the left heart failure, you will find it very difficult to even do mundane activities. Okay. The second component is of pulmonary congestion, and this is a world of itself. Of course, you have done respiratory physiology. You now understand the perils of pulmonary edema, which we discussed when we were covering those points in class. Impaired gas exchange, cyanosis, signs of hypoxia. All of this now should be clear. You have signs of hypoxia. Why is there impaired gas exchange? Is because now you have fluid in the pulmonary membrane, inside the pulmonary membrane, which has increased the area across which gases need to transfer. And for oxygen, we went into details describing that there's an optimal distance that means that the body maintains between the closest blood vessel and the nearby tissue. If you increase this area, this space, or this distance, basically you are increasing, you're decreasing diffusion across this new geography, and this will impair any gas exchange that takes place. Pulmonary edema itself then causes all sorts of symptoms. This person will have a very typical cough, a very fruity type of cough. It will be the difficulty in breathing will be especially at night, because you'll be lying down and the fluid will favor filling the lung in a bad way. The dyspnea, i.e. the difficulty in breathing, will happen at night, and then there is all sorts of this beg your pardon is the nocturnal, is the nighttime dyspnea. There will be problem with difficulty in breathing, related to posture as well. So this is basically the right and the left side failure and the clinical manifestations, right from the symptoms, these are the symptoms, and the underlying physiological concepts. We then conclude by mentioning cardiogenic shock. Shock basically means circulatory shock, and this is the last topic of circulatory unit, which we'll be discussing tomorrow. Circulatory shock has many headings and many causes. One of the cause of circulatory shock is the heart itself, where the heart gave in and resulting in circulatory shock. Circulatory shock basically is when the circulation fails to provide for the tissue oxygen and food substrates, and removing the waste material, carbon dioxide and all that sort of thing. So if that circulatory failure is not due to any failing of the circulation itself, but rather due to the heart that is pumping blood in the circulation, we call it a specialized type of shock called cardiogenic shock. Okay. MI is the most common cause of this. And what are the features? Obviously, the first feature will be decreased cardiac output, which leads to hypotension, decreased blood pressure, increased total peripheral resistance, which is due to sympathetic stimulation, obviously. because as soon as you went into hypotension, the baroreceptor reflex triggered, trying to increase cardiac output and causing vasoconstriction of the arterioles, which in this particular scenario, usually it's good, but in this scenario where the heart itself is the villain, or is the injured person, not the person, the organ, increasing TPR basically will translate into increasing afterload for this troubled heart. Okay, so in this scenario, sympathetic stimulation, besides improving blood pressure to an extent, actually causes problems by increasing afterload. The preload also increases because there is more blood coming through now, which is not being sorted out by the failing heart. It starts pooling. The whole story, which you already now know of cardiac failure, also is shared by cardiac shock. And finally, the end systolic volume is increased because it's not pumping enough blood forwards, which then increase it due to increase in afterload and decrease in cardiac function. So basically, ESV adds to the diastolic volume already present in the heart, and so a negative cycle is established within the heart of increasing fluid, and this adds to the woes of this failing heart. So a failing heart can go into a, number one, fail itself to do its job. Number two, can then trigger a shock-like situation in the circulation where the person will have cardiac failure features and features of shock, which in this case will overlap. From tomorrow, we'll discuss, when we discuss circulatory shock, you will further clear out this concept of how shock is a separate entity from failure. This is literally the boundary of cardiac failure and circulatory shock. Both features are present because heart is involved in this. When you look at more circulatory type of shock, pure circulatory type of shock where the heart is okay, then you'll be able to appreciate what shock itself is. These are references. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.